Thank you all for coming. We're going to have a great session today about topics dealing with pediatric and young adult oncology with some really great speakers today. The first, who I'm meeting for the first time, even though he's just across town, Dr. Benjamin Watkins. He's at Manning Family Children's, which I always call Children's of New Orleans, is going to be giving a talk today on new therapies for managing a really difficult problem that we have when we do stem cell transplant, which is graft versus host disease. And if I went out on a limb, I'd say abatacept is going to be mentioned here because Dr. Watkins actually was a lead author on some of the initial papers for abatacept when he was at Emory. Welcome.
All right, thank you all for having me. We're going to be talking about graft versus host disease prevention and some of the new novel approaches that are out there. I've seen a lot of changes. I've been doing this for maybe 15 years or so, and when I started this, there was like only a couple of options for the prevention of graft versus host disease. So in the past 10 years or so, we've just seen a real explosion in what we can now offer, which is really exciting. And so we'll go through some of those, some disclosures. I also wanted to start with some disclaimers. One, obviously there isn't enough time to discuss all the approaches to graft versus host disease prevention. There's a ton that are out there. And so we'll hit the high points, kind of do the 30,000-foot view. Also, I want you to take caution when I talk about some of the numbers that we're seeing when it relates to rates of graft versus host disease, because it's really difficult to compare these studies without a randomized control trial. There's so much heterogeneity in these trials. There are peds and adults, there are different donors, there are peripheral blood stem cells, there are marrow stem cells. So it's really hard to compare these without a randomized control trial. And then one of the other things that I find really challenging in the field is that there's no consensus on what outcome to measure. So when you talk about a graft versus host disease trial, we used to really focus on rates of acute and chronic GVHD because that's what the trial is for. And that's really important, but what it doesn't take into account is you can eliminate graft versus host disease, but then you may die from infection or relapse or something else. So it's really important that you actually capture both of those, because it's not just about reducing graft versus host disease, it's more complex. But then the new challenge that's now arisen is as composite endpoints has become more popular, things like graft versus host disease relapse-free survival, which tries to capture those, is that one, every study seems to define it differently, but also it equally weights graft versus host disease and death, so that you get counted as an event if you have, grade 2 or grade 3 or 4 acute GVHD that may be responsive to steroids, the same as if you died, which I don't think personally, I'd rather have GVHD than die. So I think it's really hard when looking at these studies because of this lack of consensus. So I figured I'd start by talking about some of the mechanisms of acute graft versus host disease. So the cascade of events that leads to graft versus host disease begins well before the actual transplant's given. So it may be their underlying disease or conditioning regimens, but it causes a lot of tissue damage. And so I don't know if you've ever seen anybody going through transplant. It's a really difficult process. The patients are very inflamed. That tissue damage leads to the release of chemokines, pathogen-associated molecular patterns, gut commensals, et cetera, that activate host antigen-presenting cells. So these host antigen-presenting cells go around and collect the self-antigen, express it on their surface. And in people that aren't going under a transplant, our T cells would see that self-antigen and say, that's you, ignore it, you don't need to react to it. But in the setting of an incoming graft that's filled with T cells, they'll interact with those host antigen-presenting cells and see that self-antigen and not recognize it because they recognize the donor who they're no longer in. So that interaction of those T cells and those antigen-presenting cells causes massive activation and proliferation, which leads to the symptoms of graft versus host disease, which causes more tissue damage, cytokine release, kind of feedback into it. So what I circled there in red, that's where most of GVHD prevention and acute GVHD takes place, is that interaction between antigen-presenting cells and T cells and that T cell activation. Chronic GVHD is much more complex. Acute GVHD, by comparison, is pretty simple. It's mostly driven by that T cell activation. But in chronic GVHD, you again have T cell activation, but you also have macrophage activation that leads to tissue fibroblast proliferation and scarring. You have antibodies that are being formed by your B cells. You also have decreased T regulatory cells, which shut off the massive immune response that happens with acute GVHD. So you don't have the brakes on the system. So chronic GVHD is much more complex. That's why our treatment for it is more varied, and there's a lot of different medications that are there. So I wanted to start by talking about what are the standard approaches to GVHD prophylaxis. So TAC methotrexate has been the standard, or calcineurin inhibitor, cyclosporin before TAC, really since the 1970s, early 80s. But subsequent to that, there has been a couple of new additions that have become standard of care. First one is probably the most commonly used, which is post-transplant cyclophosphamide. And its mechanism of action is really fascinating. And what you do with post-transplant cyclophosphamide is typically with the transplant, you start your immunosuppression before the graft is given so that you prevent T-cell activation. But here you actually want T-cell activation. So you don't immunosuppress them. You allow those T-cells to become activated. You see massive expansion, and then you come in 3 days later and 4 days later and hit them with cyclophosphamide, which kills the proliferating T-cells. So you're hopefully selecting the non-reactive T-cells. And those non-reactive T-cells tend to be those that are adding to our protective immunity. They're CMV specific, they're EBV specific. They're actually helping you prevent infections as you go on. So there's been lots of studies. Post-transplant cyclophosphamide has been used for decades. This is one of the recent studies. It typically had been used in the haploidentical setting primarily, but it's since come into other donor settings. So BMT-CTN 1703 was a study that compared post-transplant cyclophosphamide combined with TAC and mycophenolate mofetil to TAC methotrexate. And so the patients were randomized. This was mostly adults, and that received match-related and matched-unrelated donors. They included mismatches, but that was only 3% of the total, and this was peripheral blood. And so what was found here was that the addition of post-transplant cyclophosphamide was able to significantly reduce the rates of acute graft versus host disease as well as chronic GVHD. It also led to an improvement in the chronic graft versus host disease relapse-free survival. But interestingly, it didn't necessarily lead to a statistically significant improvement in overall survival or disease-free survival. ATG is anti-thymocyte globulin, so many of the room, I'm sure, know this drug well. This is used for a variety of different things. So this is an antibody-mediated clearance of T cells. There's multiple different antigen targets, as shown there on the bottom. And so the ATG will bind to the T cell and result in depletion of those T cells and clear them. There are a lot of different ATG formulations, though. So they don't just differ in their doses or half-lives, but also the degree of lymphopenia, their antigen targets, and their impact of graft versus host disease. The Europeans have gotten really good at using ATG. There's an art to it. Some places are using PK. They're changing the dose based on how many lymphocytes you actually have. And so we haven't really caught on as well here in the US. There's some places that are doing it, but a lot of the ATG data is not quite as good, and I think it's because they just have a better approach in how they use ATG. So the New England Journal study that came out now a few years ago, also similar to the PT-Sci study, combined it with a calcineurin inhibitor methotrexate, and it was randomized to patients that just got the calcineurin inhibitor methotrexate. This was in the match-related and match-unrelated donor setting, and so this was very similar to what we saw in the PT-Sci group. And so in this group, what we saw is that there's no significant difference in the acute graft versus host disease, but there was in chronic GVHD, really a striking reduction from 47% for moderate to severe chronic GVHD down to 11%. So ATG seems to be really effective at preventing the chronic GVHD, but maybe not as well at the acute GVHD. But again, importantly, when you look at the overall survival and disease-free survival, there was no significant difference, and at least numerically, survival was actually lower in the ATG group compared to the calcineurin inhibitor methotrexate, but didn't reach statistical significance. The other drug that's probably the most recent on this list is abatacept. So abatacept was FDA approved for the treatment of rheumatoid arthritis in the late 90s. It is a fusion protein of CTLA-4 and the Fc portion of IgG1. So what it does is as ATG binds to T cells and results in clearance, this actually binds to the antigen-presenting cell. And so it binds to the co-stimulatory molecule present on the surface of the antigen-presenting cell and prevents T cells from interacting with it. And so this prevents T cell activation, obviously, but also importantly, compared to ATG, it doesn't deplete T cells. And that's important because later on, when it comes to protective immunity, we think that ATG may have a little bit better effect because it's not depleting the T cells. So this is abatacept is a drug that I started working on in the lab in 2011 and has subsequently moved from small animal models into the adult setting. And so our large trial was the ABBA-2 trial, which again, similar to the other two, had a control arm that was calcineurin inhibitor methotrexate, and abatacept was combined with CNI methotrexate. We did two different arms, a matched unrelated donor and a mismatched unrelated donor. Importantly, this study included a large number of pediatrics. This was about 30 to 40% pediatrics. And what we found was really a pretty striking reduction in acute graft versus host disease. So our grade 2 to 4 acute GVHD was decreased in both the matched and mismatched setting. And the grade 3 to 4 was really striking in the mismatched setting. So in the mismatched setting, the control group had a GVHD rate of 32%. That was 0% with the AB arm. So none of our patients had grade 3 to 4. And historically, this may have been before Jakafi and a lot of the other meds, when you develop grade 3 to 4 acute GVHD, historically it carried about a 50% mortality rate, especially in the adult setting. So this was very promising. But importantly, it didn't seem to reduce chronic GVHD. Chronic GVHD was nearly identical between the two groups. There was no difference. However, survival was significantly improved, especially in the mismatched unrelated donor arm, with a 2-year overall survival of 77% compared to just 45% with calcineurin inhibitor methotrexate. So we haven't really come up with a consensus here in the US, but the Europeans have. Abatacept has not caught on in Europe as it has in the US. It's only approved, I think, in Germany and Israel and maybe one other country. And so they use a lot of ATG. And so this came out last year and a half ago now, that now for every type of donor that you use, they recommend either adding ATG or PTCy. And they really strongly recommend ATG. So the standard calcineurin inhibitor methotrexate, I would say, is no longer standard for the vast majority of transplants. There's a handful I would still use standard, but that's few and far between. So what is the current standard? For haploidentical setting, right now it's still post-transplant cyclophosphamide, but in the matched unrelated, mismatched, and the matched sibling, there's no clear superior agent. And so I think the approach that a lot of people use is more a personalized approach where you take into account the factors of the patient, the risk for infections, the risk of relapse, because you may choose something more immunosuppressive or less immunosuppressive based on those risks. Next, we want to talk about kind of the newer approaches and why do we need these new approaches. It's partly because despite these advancements, graft versus host disease still remains one of the leading causes of morbidity and mortality after transplant. So we really haven't solved it with agents that we have now. And all this additional immunosuppression, whether it be ABA, ATG, or post-transplant cyclophosphamide, comes at a cost. You get delayed immune reconstitution, increased infections. Sometimes, especially in the PTCy setting in pediatrics, the graft failure rate was quite high. It was 16% in the most recent one. So that's definitely a concern in certain settings. And then its impact on graft versus leukemia. And so there's really a need to try to thread that needle between GVHD risk and the toxicity. And so we'll go through several different categories of these new approaches, starting with new approaches using these proven agents that I just talked about. So one of the upcoming studies that's ongoing now is Optimize. So the Optimize study is actually looking at reducing the dose of cyclophosphamide post-transplant. So the dose of 50 mg per kg at day 3 and 4 is something we've used for decades. That was largely based on some animal model. No one's ever deviated from it. I think a lot of us think that maybe we don't need that much cyclophosphamide, but are too afraid to lower the dose. And so that's what this study is doing, is looking at dropping it from that 50 down to 37.5, and then if that's successful, to drop it to 25. And this is highly mismatched donors, 4 to 7 out of 8 unrelated donors. So that study, we don't have data on that yet, so that study's ongoing. Abatacept has also got several ongoing trials. And so there's several different groups that are looking at, can we extend the dose? So the standard approach with abatacept is giving doses on day -1, 5, 14, and 28. And so the thought is that may be too short to really affect chronic GVHD, because by day 60 or 70, all the abatacept is gone. Those T cells are now able to become activated, and so the onset of chronic GVHD is after that period. So can we extend it out to either day 150 or even to 1 year, especially in the setting of a non-malignant transplant? And there's been some mixed results on that. So there's really positive results in some of the sickle cell data that's shown a really impressive reduction in chronic GVHD with that extended dosing. And so our follow-up to the ABBA-2 study is the ABBA-3 study, which is we've closed to accrual other than our very young patients, but this is looking at randomizing between that standard 4 doses or extending it out to day 150, and this is pediatrics and adults. And so more data to come with that. I don't know if that's going to be the answer for chronic GVHD. I think we'll probably still see it. We may just be kicking the can down the road with abatacept. I think maybe the real answer is actually combining it with other agents, which we'll talk about subsequently. And then there has been a study looking at a calcineurin inhibitor-free transplant. Those who are familiar with transplant know a lot of our complications are coming from our calcineurin inhibitors, and it's really challenging. And so we'd love to find a way that we can get away without tacrolimus or cyclosporin. And so the CTN 1301 was a study that was published a few years ago. That was a phase 3 study that was randomized to just CD34 selected, so just collecting your stem cells, eliminating all of your T cells, since those are the ones that cause the problem. Then comparing that to just standard post-transplant cyclophosphamide, and then comparing that to TAC and methotrexate. And so interesting, what they found is CD34 selection is excellent at getting rid of graft versus host disease. So it had the lowest rates of acute GVHD and chronic GVHD, but it also had the highest rates of relapse and infections. So the overall survival was actually significantly lower, despite the acute and chronic GVHD rates being so low. And so CD34 selection, that standard approach, doesn't seem to be the answer. And then when they compared post-transplant cyclophosphamide and TAC methotrexate, they saw no significant difference between those. And so that with just post-transplant cyclophosphamide, it doesn't seem to be enough to do a calcineurin inhibitor-free transplant. And so again, I think one of the best approaches moving forward, in my opinion, is actually a combination of agents. And so one of the ones that there's several different trials looking at this, but they call it CAST, which is a combination of post-transplant cyclophosphamide plus abatacept, and in this case, plus tacrolimus. So this is a phase 1b/2 trial. There's several other trials that are, again, out there, but looking at this in the haploidentical setting. And so what they found with this regimen is that really low rates of acute and chronic GVHD and encouraging survival. And so they didn't have a control arm, but the rates of grade 3 to 4, the most severe acute GVHD, was very low, as was the chronic GVHD, and the 1-year overall survival was 86%, which is quite reassuring with this patient population. There's still more approaches trying to get towards calcineurin inhibitor and free transplant. Again, the PTCy alone doesn't seem to be the answer, so this is one that's actually trying to combine PTCy plus ABBA, so it's using ABBA extended dosing as kind of your maintenance to prevent GVHD, and combining that with post-transplant cyclophosphamide. So this was presented at ASH. I think this is due to be published within the next month or two. So this was a phase 2 randomized trial, and it showed, again, low rates of acute graft versus host disease, but importantly, zero patients developed moderate to severe chronic GVHD, and the one-year overall survival was 92%. So this seemed really encouraging. So there's several other centers that are out there looking at this ABA-PTCy combination. And then also wanted to share a little bit about some of the newer agents being evaluated. One of these is vedolizumab. Vedolizumab is a drug that's FDA approved for the treatment of Crohn's disease. It's a humanized monoclonal antibody that binds to the alpha-4 beta-7 integrin leukocyte receptor. It blocks the interaction between the MAdCAM1 on endothelial cells and the GI lymphoid tissue, and it prevents the alpha-4 beta-7 expressing T cells from actually entering the gut tissue. And so this study was really focused on gut GVHD because this is really only active in the GI tract. It is not going to do anything to prevent skin or liver graft versus host disease. And so in combination with the calcineurin inhibitor, they found that there was a significant reduction. That's kind of hard to see on this slide, but the gist of it is that it was really effective at reducing lower GI GVHD, but again, has no impact on skin or liver, and unknown impact on chronic graft versus host disease. JAK inhibitors are also drugs that we use on a very regular basis in the treatment of acute and chronic GVHD. So this is Jakafi as an example of it. There's several different JAK inhibitors that have been evaluated. JAK inhibition reduces differentiation, proliferation, and trafficking of T cells. So the three primary ones that have been evaluated are itacitinib, pacritinib, and ruxolitinib. Itacitinib is a JAK1 inhibitor. Pacritinib is a JAK2 inhibitor. I'm not going to show that study because it showed no improvement. And then ruxolitinib is a combined 1-2. And so the itacitinib trial was just a single-arm study, included 59 patients. It was a phase 2 study. There are limited data that's out of this. This is from an ASH meeting a couple of years ago. Median follow-up was only 6 months, so can't really comment on chronic GVHD, but the rates of acute GVHD overall seemed not that impressive, 8 to 10%. So we'll see when the long-term data comes out. Itacitinib's also been combined with post-transplant cyclophosphamide, and so that's been encouraging with low rates of acute and chronic GVHD. This was presented at the transplant meeting last year. It's only 30 patients, but it does seem to be promising. And then the one that I think probably has the most promise, the drug we're most familiar with, is the combination of ruxolitinib with TAC and methotrexate. And so this phase 2 single-arm trial, this was focused on older adults because they weren't able to tolerate some of the more intense GVHD preventions. Again, showed encouraging reduction in grade 3 to 4 in chronic GVHD. The ongoing study is called BMT-CTN 2203, which is going to randomize between ruxolitinib, TAC, methotrexate, and post-transplant Cy, TAC, and MMF. And this is one of the few studies that is actually randomized between two approaches using something more than calcineurin inhibitor methotrexate. And then the last group I'm going to talk about is graft manipulation, which also shows a lot of promise, but is logistically more challenging. So the one that's shown the most promise and has the most pediatric data is alpha-beta T cell depletion. So the limitation, as I mentioned before, of the CD34 selection is patients die of infection, they relapse. If you eliminate all the T cells, you're going to have bad consequences of that. And so alpha-beta T cell depletion is really looking to thread the needle because alpha-beta T cells have been shown to be the ones that cause graft versus host disease, whereas gamma-delta T cells have no alloreactive activity, but do play a role in graft versus leukemia and innate immunity. So how can we have both prevention of GVHD and still maintain our GVL? And so this study, which was a phase 1-2 trial, this was all in pediatrics that combined alpha-beta T cell depletion with CD19 depletion in haploidentical settings. It showed really low rates of acute and chronic GVHD, 0% in the chronic GVHD moderate to severe. Importantly, these patients did not require calcineurin inhibitor. What was also seen is it's not as perfect as we had hoped, that you still see delayed immune reconstitution, and they saw frequent viral infections. 62% of patients had viral infections at 1 year. And so it's not quite as perfect as we had hoped, because you still definitely have some immune suppression. But they actually have 10-year data, which you never see in transplant, with still really promising results as far out as 10 years, with overall survival of 75%. Naive T-cell depletion is another approach, again, focusing on trying to maintain your innate immunity but eliminate your GVHD risk. So alpha beta T cells include naive, effector, and the memory subsets. Your naive T cells seem to be the ones that cause most of the graft versus host disease. So this is look at eliminating those naive T cells. And this is also a pediatric study by Marie Bleakley out of Seattle. And so what they do is actually collect the CD34 T cells, and then they deplete the CD45RA, which is a naive T cells, and then you infuse it back, combined with tacrolimus and methotrexate. And again, very low rates of grade 3 to 4 acute GVHD and moderate to severe, but they saw a lot of the more mild forms of GVHD for some reason. So the subsequent study is ongoing. So that's this phase 2 study, which we don't have results of yet, but will shortly. And then lastly is the ORCA-T. So ORCA-T is relatively new to the game. What this is CD34 selected Treg engineered graft. So what they do is they collect the stem cells and separate out stem cells, Tregs, and conventional T cells. And so they purify them separately. On day 0, they give the stem cells and they give the Tregs and allow the T regulatory cells to expand, because again, T regulatory cells are the ones that shut off your T cell activation. And so then 2 days later, they infuse the conventional T cells, but they do it at a ratio of 1-to-1 with your T regulatory cells. So trying to control how many of those T cells that you have there. And so this was presented at EBMT last year, and also at the TCT last month. And so this phase 3 randomized study of 138 patients, this was randomized to ORCA-T and TAC versus TAC methotrexate. Really what showed an impressive reduction in graft versus host disease in both the chronic GVHD and a chronic GVHD-free survival. And so there's more to come with that study, but in conclusion, I think the standard of care for GVHD prophylaxis is still very much up for debate. That's the exception to that is PT-Cy for haploidentical transplants. I think that's still very much the standard. We've shown that PT-Cy, ATG, ABA, all of these have shown superiority to standard calcineurin inhibitor methotrexate in multiple randomized control trials across many different donor types, and that calcineurin inhibitor methotrexate should no longer be considered the standard of care when choosing a control group too, because I think clinically that's not what we're doing. But there's obviously need for more head-to-head comparisons to find out really which one of these agents may be superior. And there's multiple novel approaches to GVHD prevention that have shown promise. There's none of these that seem to be superior. There's several out there that seem to have hope. And I think it's important to remember that every agent that we use comes with its own risks and benefits, and we have to keep in mind that we should be basing our approaches off of the patient that's in front of us and their individual risk factors. So with that, I'm happy to take any questions. Yes, Bob.
That was a really nice summary. It's kind of funny to me that we translate, you kind of talked about this in doing these studies. In pediatric oncology, we tend to all do the same thing. That's not for transplant. Hold on to a lot of things. Like our colleagues in the state next to us love CAMPAT. Data on CAMPAT. Outside of tools, I don't see a whole lot, but what do you think about it?
And I think you're hitting on a point is I think one thing that I've talked about too before, so much of it is the devil you know, right? Like we used a lot of ABA in Atlanta. We were running a clinical trial. We knew our risks. We really knew it in and out, and it could be successful in that setting. I think our colleagues at Johns Hopkins, like they're very comfortable with PT-Cy for everything that they do. Other centers are really comfortable with doing cord transplants and others aren't. So I think so much of it is the devil you know. And so I think there are definitely reports out there having success with CAMPath. I don't tend to use a lot of CAMPath because I just don't have the experience, and I think I wouldn't be probably doing it right because there's an art to it. And so I think that's probably part of it is, yeah. No. Yeah, Corey.
Yeah, so with the alpha beta depleted T cell grafts with a high viral infection rate on that study, was it, were they like severe viral, or were they like mortality, I guess, was it significant from infection?
No, I didn't think so. The problem with these studies, and we ran into this with our ABBA study, is the more data you publish, the more people pick apart, right? If you look at the PT-Psi study, they give you nothing. They don't give you CD4 counts. They don't give you viral infections hardly ever. So the data looks beautiful because they don't but if you start showing that data, you're going to be drawn to it. So what it does show is that your CD4 count at day 100 is lower with alpha beta. They weren't dying from these infections. The 10-year overall survival was 75%, which is pretty good for a transplant patient. And so I don't know if it's as problematic as it was initially maybe thought to be. All right, I think that's it. Thanks, Tim.